and hemorrhagic and pernicious anemia. We looked at polycythemia. Polycythemia was an increase in RBCs, so the blood became very thick. There was a specific polycythemia called polycythemia vera. Polycythemia vera indicated bone marrow cancer. We moved to the white blood cells, the leukocytes, the white blood cells. The white blood cells we divided into granulocytes and agranulocytes. The granulocytes were the neutrophils, the eosinophils, and the basophils. The agranulocytes were the lymphocytes and the monocytes. There was a saying that tells you how they occur normally in the body. Never let monkeys eat bananas. N, neutrophils. L, lymphocytes. M, monocytes. E, eosinophils, and bananas, basophils. So never let monkeys eat bananas. We talked about the leukemia and the cells that they come from. When you look at the leukemias, it involves the stem cell, the hemocytoblast, produces a myeloid stem cell and a lymphoid stem cell. The myeloid stem cell is the mother of the myeloblast, the mother of the granulocytes. So if we have myeloid leukemia, then it involves the granulocytes or the monocytes. If it is lymphocytic leukemia, then it involves the lymphocytes. And the cell, the blood does not lose its lymphocytes. The blood fills up with immature, non-functioning white blood cells. We looked at blood clotting, hemostasis, the stoppage of bleeding, and the coagulation and clotting. Coagulation, or blood clotting, transforms blood from a liquid to a gel in a three-stage process, ending in the conversion of fibrinogen to insoluble fibrin threads. The fibrin threads glue the platelets together and act like a mesh to capture the formed elements to form a stable clot. We talked about hemophilias. There was hemophilia A, hemophilia B, and hemophilia C. A and B were sex-linked hemophilias. Remember, sex-linked meant that it was passed from mom to her sons. Hemophilia C, not sex-linked, so both sexes can get it. Hemophiliacs lack procoagulants. Hemophiliac, the bleeders, do not have enough procoagulants. Hemophiliacs lack procoagulants. We talked about transfusions and blood replacements. Transfusions. If we lose 30% of our blood volume, we have to get something in the pipes to prevent vascular shock. We talked about the A, B, and O blood groups. A blood has A antigens and B antibodies. B blood has B antigens and A antibodies. AB has both A and B antigens and no antibodies. O blood has no antigens and both A and B antibodies. So O blood, or O negative, when it comes to the Rh, becomes the universal donor. Erythroblastosis fetalis. When mom has a baby, a newborn, Rh negative mom has a Rh positive babe. That first babe not in danger. It's the second babe that is in danger. And so mom gets those injections now. We didn't tell you RhoGAM injections to take care of that. We talked about plasma and volume expanders. Remember we said that if you had a patient that lost more than 30%, did you need to give him whole blood? You just need to fill the pipes. You can use plasma. You can use normal saline. There's lots of expanders on the market if you're in a hospital or some Dextrain. There's all kind of things. But you got to fill the pipes. Otherwise, the heart can't pump the blood. We talked about tonight our heart the heart, the cardiovascular system. It was located in the mediastinum. It was 2/3 to the left of midline. The apex connects to the chest wall between the 5th and 6th rib. It doesn't connect to, it contacts the chest wall between the 5th and 6th rib, and we call that the PMI, the point of maximal intensity. The heart has some coverings. It had a fibrous pericardium around the outside that prevents overfilling, and then it had the serous pericardium. Remember, serous membranes, an outside parietal layer and an inside visceral layer. The inside visceral layer of the serous pericardium is the same tissue as the epicardium. So we got the coverings covered. The epicardium, same as the visceral layer of the pericardium. The myocardium, the muscle layer, the bulk of the heart, made up of muscle cells that are branched. They're held together with fibrous connective tissue. They had an intercalated disc that was made up of gap junctions and desmosomes. We started to look at our heart chambers. The atria were the receiving chambers. The ventricles were the discharging chambers. We had atrioventricular valves, AV valves, one on each side, the tricuspid on the right side, the bicuspid on the left side. We looked at the atria and the ventricles. The atria were receiving, ventricles were discharging. We got some external landmarks. The atrioventricular sulcus marks where the atria and the ventricles come together. The anterior and posterior interventricular sulcus marks where the interventricular septum comes through, that little groove in the front and the groove in the back. There were some valves. Valves prevent backflow. The AV valves from the atria to the ventricles, the semilunar valves from the ventricle into their vessels. The semilunar is named for the vessel that the blood goes into. So the left ventricle sends its blood through the pulmonary semilunar that goes to the lungs. The left, did I say that right? The right ventricle sends blood to the pulmonary semilunar into the pulmonary trunk. The left ventricle sends blood through the aortic semilunar into the aorta. The valves prevent backflow. We looked at circulation of blood through the heart. Do we need to go through that? No? Yes? Anybody? Yes? Blood drop beginnings in the right atria, passes through the tricuspid valve into the right ventricle. From the right ventricle, passes through the pulmonary semilunar into the pulmonary trunk. Pulmonary trunk splits into the right and left pulmonary artery, taking blood away from the heart to the lungs. The lungs exchange of gas. From the lungs, it comes back to the right atria through 4 pulmonary veins. From the right atria, it passes through the mitral valve, the bicuspid, or the left AV into the left ventricle. The left ventricle in through the aortic semilunar into the aorta. Smaller arteries, capillaries, veins, larger veins, inferior, superior vena cava, back into the right atria. All good with that? Okay. Did we have some blood flow to the heart, to feed the heart? 2 coronary arteries, a left one and a right one, each of them fork to make 4, 2 on each side. The left one splits into the anterior interventricular and the circumflex. The right one splits into the marginal and the posterior interventricular. If we send blood out, then we have to pick it up. So we pick that blood up in 3 veins. The great cardiac vein picks up all the left side. The small cardiac vein picks up the marginal artery blood, and the middle cardiac vein picks up that in the posterior interventricular septum. We looked at where that blood supplied, what it did in that heart. That left coronary, left side of the heart, The circumflex supplies the left atrium, the posterior walls of the left ventricles. The right side does the right side of the heart, the posterior interventricular and the marginal artery vein. We looked at properties of the cardiac muscle tissue. Remember we said that it had intercalated discs, and those intercalated discs were made up of gap junctions and desmosomes. We talked about some of the muscle contraction. Cardiac muscle contraction requires extracellular calcium. Remember, it has to pull 20% of its calcium from outside. So cardiac muscle requires extracellular calcium. We looked at some of the heart physiology and the intrinsic conduction system up here. The SA node discharges or depolarizes 75 pops a minute. The AV node, 50. The bundle of His, 30, and the bundle branches in the Purkinje fibers, 30. So which one's in charge? SA node's in charge. It sets the pace. Arrhythmias, irregular heart rates, or heart rhythms. Fibrillation, out of phase contraction, really fast. Modifying the basic rhythm, we had some extrinsic innervation to the heart. Remember, there was some things that we could do from outside, that coffee and all that kind of stuff. Then electrocardiography. Remember this guy over here? P wave, QRS, and T wave. P wave, atrial depolarization and contraction. QRS, ventricular depolarization and contraction. T wave, ventricular repolarization. Atria repolarize at the same time that QRS appears. Abnormalities, no P wave, SA node non-functioning. Extra P wave, second degree heart block. Some of the SA node impulses do not get conducted through the AV. A chaotic, no pattern ECG or EKG is ventricular fibrillation. We talked about heart sounds, lub, dub. We get heart sounds from valves closing. Lub, the AV valves closing. Dub, the SL valves closing. Murmurs, abnormal, unusual heart sounds. Murmurs, your textbook says because of valvular insufficiency. But remember, anything can do it. Valvular insufficiency. We looked at cardiac outputs, and cardiac output was heart rate times stroke volume. Stroke volume normally around 70 milliliters. Heart rate about 75 beats a minute. So 75 beats times 70 milliliters gives us 5,250 milliliters, about 5 1/4 liter. We looked at heart rate and stroke volume. There were three things that affected stroke volume: preload, contractility, and afterload. Preload, how much we stretch the muscle before we contract. Contractility, how healthy that muscle was, irregardless of how much we stretched it. And afterload, how much pressure was pushing back against the valves. Of those three, afterload affects cardiac output the most. We looked at the autonomic nervous system control of the heart. We use parasympathetic tone. That parasympathetic tone comes through the vagus nerve, so we call it vagal tone. We looked at rapid heartbeat, tachycardia, over 100. We looked at bradycardia, slow heart rate, less than 60. We talked about some age-related factors. If we fibrose the muscles around the intrinsic conduction system, the system itself becomes fibrosed. So as we age, we get irregular heartbeats. All right. We did good. That's 840. Test next week. After the test, we're going to move on into the next chapter.